Hello, I'm Donna Krolik, and I'm a BSN graduate of St. Pete College here last year. I'm a new initiative program tutor, and today I will be covering the neonate. We'll be going over a transition to extrauterine life, initial assessments and tasks, APGAR scoring, physical assessment, reflexes, the neonate at risk, feeding, and discharge preparation. The transition from fetus to newborn is the most complex physiological adaptation that occurs in the human experience. Prior to medicalization of delivery, the transition had to occur quickly for survival of the newborn. All organ systems are involved at some level, but the major immediate adaptations are the establishment of air breathing concurrently with changes in pressures and flows within the cardiovascular system. The essential components for normal neonatal transition are for clearance of the fetal lung fluid, surfactant secretion and breathing, transition of fetal to neonatal circulation. There's a decrease in the pulmonary vascular resistance and an increase in pulmonary blood flow due to the cutting of the cord and the pressing of the fluid out of the lungs during birth. And of course, there's endocrine support for the transition. This is a little graphic of this fetal circulation. You'll see that the placenta down at the bottom left is from the mom, and oxygenated blood is carried from there to the inferior vena cava by the umbilical vein. It enters the right ventricle, where some of it mixes with deoxygenated blood from the superior vena cava. Some of it passes through the foramen ovale into the left side of the heart, where it is pumped into the aorta and to the brain and body. The mixed blood from the right atrium passes down into the right ventricle, and then this is forced up by the pumping action of the heart, where it flows through the ductus arteriosus because the pressure of the pulmonary arteries is too high. The reason for that is the lungs are filled with fluid. The fetal blood is mixed, and the umbilical arteries carry the blood back to the placenta for oxygenation. When the umbilical cord is cut, there's a rapid physiological change that occurs. And the most critical adjustment is that the newborn makes at birth is the establishment of respirations. When the neonate takes its first breath, a sequence of events occurs. Since there's now oxygen in the lungs, pulmonary vascular resistance is lowered. There is decreased pressure in the right atrium, ventricle, and pulmonary arteries. The systemic vascular resistance is high, increasing pressure in the left atrium, ventricle, and aorta. The umbilical vessels are no longer needed, and they lose their function and eventually become ligaments. The ductus venosus, which is the connection of the umbilical vein to the inferior vena cava, becomes a ligament, and also the ductus arteriosus, which is the shunt from the pulmonary artery to the descending aorta. The foramen ovale closes because of pressure changes and eventually fuses closed permanently within several months, up to a few years in most people. Neonates who cry hard can sometimes turn slightly blue because of the foramen ovale opening from the pressure. Newborns undergo different phases of instability during the first 6 to 8 hours after birth. The first period of reactivity lasts up to 30 minutes, where the heart rate increases from 160 to 180 beats per minute. Respirations are irregular and can range from 60 to 80 breaths a minute. Upon auscultation, you may hear fine crackles, you'll hear audible grunting and see nasal flaring or retractions, but they should cease within an hour. Startles or tremors, crying, and movement of the head from side to side are present, and you'll hear bowel sounds, and the baby may pass meconium at this time. This is followed by a rest period where the heart rate falls to a baseline of 100 to 120. The neonate usually sleeps at this time, and this period can last from 60 to 100 minutes. That is followed by a second period of reactivity, which occurs 4 to 8 hours after birth and can last from 10 minutes to up to several hours. Brief periods of tachycardia and tachypnea, increased muscle tone, skin color, and mucus production. This is a common time for meconium passage. You can see periods of apnea in the infant, but if you see anything longer than 20 seconds, that should be further evaluated. Immediate tasks for the nurse as soon as you have a newborn baby are to verify that respirations are established. That means that you will be clearing the mucus from the mouth and the nose. You will be drying the infant off, assessing temperature, placing ID bands on your mom, the baby, and the significant other. In some settings, immediately after birth, a baby is placed onto mommy's tummy to maintain warmth and promote bonding, and in some places, the babies are placed under the warmer. The initial exam can occur while the nurse dries and wraps the infant or while with the mom. If the baby is pink and has no life-threatening anomalies or risk factors needing immediate attention, further examination can be delayed so that baby and mom can bond. Nursing interventions, of course, first is always airway in anything that you do in nursing, ABCs. You would use the bulb syringe to suction the mouth, first along the sides. You would depress the bulb syringe before even putting it into the mouth of the baby, and do not put it down the center of their mouth. Suction along the sides. The nose is then suctioned. It's always kept in the infant's crib, the bulb syringe, and teach the parents its proper use. Remember that you must maintain temperature because cold stress depletes glucose stores and increases the respiratory rate. Stabilize the infant by drying him, placing him directly on mom, and wrap the baby in a pre-warmed blanket and cover his head. Or maybe the baby can be placed under the radiant warmer or in an incubator also. Eye ointment is placed in the eyes to prevent ophthalmia neonatorum, which is caused by gonorrhea or chlamydia. Usually this is erythromycin or tetracycline. Vitamin K is given IM routinely to prevent hemorrhagic disease. This can be delayed until after breastfeeding in the birthing room. Healthy newborns can make their own by day 8. This is done in the gut, and bacteria is needed for it to happen. Babies are born with very little vitamin K, and studies show that vitamin K deficiency bleeding happens in breastfed babies exclusively. The reason for this is that the infant formula contains vitamin K1, and it has 100 times more than breast milk. Vitamin K1 is found in plants, and vitamin K2 is made from the bacteria in the gut. 90% of our overall vitamin K levels are from K1. So cord care is determined by the facility. Triple dye, bacitracin, alcohol, soap, and water are used. Current recommendations by the Association of Women's Health, obstetric and neonatal nurses include using sterile water initially. Triple dye treatment has been shown to be superior to the others in reducing colonization or infections. Alcohol use has been shown to actually prolong cord drying. When I was an OB nurse 100 years ago, we used to use alcohol, but things changed. Now we're in the age of medicine, or evidence-based medicine. Always assess the cord stump anytime when you're changing diapers Check for edema, redness, drainage with every diaper change. The clamp can be removed around 24 hours if the stump has started to dry and is no longer bleeding. Signs of respiratory distress are nasal flaring, intercostal or subcostal retractions. You'll hear grunting with each respiration. You'll see paradoxical respirations, and paradoxical means that the respirations are not even. One side of the chest will raise and the other side won't, or you'll have an abdominal raising and a chest sinking down. It's uneven breathing. And you'll have unusual respiratory rates like under 30 or at rest above 60. So the rate may be due to effects of analgesics or anesthetics administered to mom during labor and birth. Apneic episodes can result from a rapid increase in temperature, so monitor the temperature when that baby is underneath your warmer. Make sure that you have the baby, a little patch on the baby that's connected to your warmer, and it monitors the skin temperature automatically. Apneic episodes can also result from hypothermia, hypoglycemia, and sepsis. Tachypnea can be due to inadequate clearance of lung fluid or a sign of respiratory distress syndrome. Babies who are C-section babies don't go through the birth canal, so they typically are the ones that might have these problems. They haven't had all the fluid squeezed out of their lungs. During the first hour of life, the lymphatics remove large amounts of fluid. If this fluid's not cleared, it can compromise respirations, especially in cases where there's meconium aspiration, congenital diaphragmatic hernia, esophageal atresia with a fistula, congenital cardiac defects, or immature alveoli. Lung expansion is largely dependent on chest wall contraction and adequate presence and secretion of surfactant. Surfactant is the substance that lowers surface tension, sort of like soap and water. If you were to take a shower and you go in the shower and you rub your skin and feel your skin, it feels a lot different after you put soap on. It's slipperier. So that's what surfactant does. It reduces the pressure required to keep the alveoli open with inspiration and prevents collapse on exhalation. So with a cardiovascular system, the average rate, heart rate is from 120 to 140 beats per minute, and it varies with activity, just like adults, around 85 beats per minute while the baby is sleeping, and can go up to 170 or 180 with crying. Always use the apical pulse and assess for an entire minute. Murmurs can be heard early, but most disappear by 6 months. Blood pressure can run systolic 60 to 80 and diastolic 40 to 50. The presence of a murmur with apnea, poor feeding, cyanosis, or pallor are abnormal and should be investigated. Blood pressure is assessed initially, but not normally routinely. It depends upon your facility also. It is important to choose the correct cuff size if you are going to do a blood pressure. Apical pulse is located at the 4th intercostal space and to the left of the midclavicular line. And because the chest wall is so thin, it's easily palpated in an infant. It is always important to remember about thermoregulation in infants, because this is the second most critical element to the newborn survival. If the baby is too cold, then we can have problems. Here are different ways that babies can lose heat. It can happen in 4 ways: conduction, convection, evaporation, and radiation. Conduction is the loss of heat from the body to a surface by direct contact, such as in figure A, where the baby, you lay the baby down on a scale, and it's a metal scale, and you neglect to put a blanket or something down on top of it, and the baby loses heat to the metal surface, just as if you were naked and laid up against something metal, you would lose heat too. The second method, B, is convection, and that's the flow of heat from the body into the air. If a fan blows on you, that's convection. C is evaporation, and that's loss of heat from the body when liquid is converted to a vapor. So when you take a shower and you walk out of a nice hot shower into the air, you get cold because your skin evaporates, the moisture is evaporating. And the third is radiation. This is a loss of heat from the body to a cooler, solid surface that's not in direct contact, but in relative proximity. So placing baby skin to skin with mom and covering them both is a good way to enhance temperature control and interaction. Because infants have a larger body surface or surface to body weight ratio than children and adults. Cold stress places demands on metabolic and physiologic function in newborns. Oxygen consumption and energy are diverted from maintaining normal brain and cardiac function and growth to thermogenesis for survival. If oxygen levels diminish, vasoconstriction follows, affecting pulmonary perfusion. PO2 decreases and blood pH drops. Basal metabolic rate increases, and if cold stress lasts for an extended period, anaerobic glycolysis occurs, increasing production of acids, and that leads to metabolic acidosis. Hypoglycemia is another consequence of cold stress. Anaerobic glycolysis uses 3 to 4 times the blood glucose, and that depletes stores of glucose. Hyperthermia is also a risk to newborns as their sweat glands do not function very well. Hypothermia can lead to dehydration, heat stroke, and death, so monitor your children who are in warmers. APGAR scoring is a method to rapidly assess the neonate's transition to the extrauterine environment. Scoring is done with different indicators. They are heart rate, respiratory rate, muscle tone, reflex irritability, and color. Muscle tone is based on the degree of flexion and the movement of the extremities. The pulse, you would auscultate the apical pulse for a full minute with the stethoscope. And the reflex irritability is based on a bulb syringe or a catheter inserted into the nasopharynx. Skin color is described as pink, cyanotic, or pallid, and respirations are based on observed movements of respiratory efforts. So if you have no heart rate or no pulse, that baby gets a 0 APGAR score for that category. However, if the heart rate is less than 100 beats per minute or sluggish, the infant gets a 1 score. Strong heartbeat and 100 beats or more is a 2 score. APGAR scoring is done at the 1 minute and 5 minutes after birth. Here's some photographs of the difference between central cyanosis versus acrocyanosis. The baby on the left, it has central cyanosis, and you can see he's bluish all over his body, whereas the baby on the right has just the bluish hands and feet and is pink everywhere else. So we're on to the physical assessment. An external exam is done. We're going to look at the skin color, the palms and the sole creasing, meconium staining, length of the nails, any lesions on the skin, birthmarks, any caput succedaneum or molding, forceps marks, vacuum extraction, lack of subcutaneous fat. We're going to observe his respirations and note any activities. With the chest, we'll Auscultate the apical heart and listen to the lungs. For the abdomen, we note the characteristics of the abdomen, auscultate bowel sounds, and note the number of vessels in the cord and its appearance. For a neurologic assessment, we would check for muscle tone, palpate the fontanelles, noting any depressions or bulging of the anterior fontanelle. In the genitourinary system, you would note the sex, any abnormalities that you would see, check anal patency, and the only way we check for that is by a positive passage of meconium, and also note if you have passage of urine. Any gross malformations or conditions that require intermediate interventions should be noted, such as an omphacele or a meningeocele. This initial assessment can be done under a radiant warmer or when placed skin to skin with mom. Take care to minimize interferences with bonding. If baby is breathing fine, pink, and has no immediate health results, such as mom being a diabetic, then further examination can be delayed until mom and dad have bonded with baby. So make sure that when you do your newborn assessment, when we're talking about the complete assessment, that the environment is quiet and warm, and you want to start with least invasive procedures first so that you can keep the baby quiet. You will undress one body part at a time to keep the baby warm, and do this in an orderly sequence from head to toe. Proceed quickly and comfort the infant when needed. So this complete examination is done within the first 24 hours of life, and normally upon the admission process. So we want to keep your infant warm and start with the least invasive procedures, such as observation of respiration, position, skin color, tone, and condition. Then auscultate the heart, one heart, two lungs, I said, and the abdomen. Measure the head and the length, and follow lastly with the more disturbing procedures such as reflexes. You want to proceed quickly so as not to stress the infant. You can comfort the infant by giving them a gloved finger to suck on. You can speak softly to them and swaddle them, and you can hold their hand against their chest. If you have a screaming baby, I have found that one of the best things to do is to lean over and whisper in their ear, and they stop screaming immediately. And then you can swaddle them. They're used to being in utero and being in a little tight environment, so that actually does calm them. The next thing we're going to do is check for gestational age. We do that by using the new Ballard score, and it's used to measure maturity of the infant. Physical maturity is assessed by observing body elements, such as the skin, the presence of lanugo hair, breast tissue, plantar creases, ear cartilage, and genitalia. Typically, post-mature babies will have cracking and peeling skin with no vernix, caseosa, or lanugo. Neuromuscular maturity is assessed with different maneuvers that are performed with moving the infant's arms and legs. Flexion and angles are observed and noted, and then scores are given. Classification of newborns. We give infants are classified based on maturity and intrauterine growth. We use head circumference, weight, and length to assess them in percentile scales. AGA, or appropriate for gestational age, are those infants between the 10th and the 90th percentile. Above the 90th percentile are called large for gestational age babies, and below 10% are called the small for gestational age. Gestational age is important to assess because it can predict mortality risks. Some common newborn problems: soft tissue injuries, subconjunctival, retinal hemorrhages, erythema, ecchymosis, petechiae abrasions, lacerations, or edema. You can see localized bruisings from forceps or presentation during birth. About half of all newborns appear jaundiced during the first days of life. Infants are at a high rate of bilirubin production and reabsorption, and that occurs in the small intestines. If levels persist, the infant is treated under phototherapy lights. The eyes are protected with pads and a mask, and the infant is placed in a warmer with the lights on. Maximal skin exposure is utilized. Monitor the temperature and the hydration levels by watching urine output and weight. Bilirubin is excreted in the stool. Hypoglycemia means low blood glucose, as you know. You want to observe within 2 to 3 hours after birth, and this is recommended especially for infants at risk. Moms who have altered metabolisms, diabetes, gestational hypertension, terbutaline administration, or newborn factors such as pericongenital malformations, hyperinsulinism, small for gestational age, and fetal hydrops are all at risk. Hypocalcemia is another problem. Infants of diabetic mothers who have had perinatal asphyxia or trauma, low birth weight, and preterm infants are all at risk. Signs include jitteriness, a high-pitched cry, irritability, apnea, intermittent cyanosis, abdominal distension, laryngospasm, although some phyocalcemic infants are asymptomatic. Jitteriness is a symptom of both hypoglycemia and hypocalcemia. So if therapy for hypoglycemia is ineffective, consider hypocalcemia. Routine PKU testing is done on all infants, along with other testing such as galactosemia, maple syrup urine disease, and others. PKU can result in mental retardation. These babies can't break down an amino acid called phenylalanine, and that's actually found in diet soda. It's aspartame. So if you look at your diet soda and it says caution, phenylketone urics, beware, don't drink that. You shouldn't be drinking diet soda anyway. Newborn reflexes. Reflexes help identify normal brain and nerve activity. So that's what we're checking when we check newborn reflexes. Rooting is when the infant will turn his head when the cheek is stroked. So these are reflexes babies are born with. So if you stroke the cheek with your finger, that baby's going to be looking for the nipple. It will be turning his head towards you and trying to grab a hold. This disappears around week 6. Sucking, the infant will begin to suck when the lips are touched. It disappears around 6 months. Swallowing is the same as an adult. Extrusion occurs when the tip of the tongue is touched or depressed and the newborn forces the tongue outward. So if anything is in the mouth, it's pushed outward. This disappears at 4 months. Tonic neck is also called the fencing position. When you turn the infant's head to the side, he extends that arm and the leg on that side. This disappears also in 2 to 3 months. The palmar grasp is when the infant's palm is touched and he grasps it. So if you put your finger in the palm of the infant's hand, he will immediately grab your finger and hold on. He'll also grab your hair too and pull, so beware. This disappears in 6 weeks to 3 months. Step in place is a reflex in which when you're holding the infant up into a standing position and his feet touch a solid surface, he actually starts walking, stepping. That all disappears in 3 months. The Moro reflex is also called a startle reflex, and that's when both arms abduct and extend. The fingers extend out. So if there's a loud noise or something hits the crib, the arms and the legs just extend really fast, like woo, you know, and pull back. Babinski is the reflex where the toes flare out when the foot is stroked from heel to toe along the lateral edge of the foot. Changes to the adult reflex in 3 months. Here are some photographs of the rooting, sucking, and tonic neck reflexes. The Moro reflex, you can see the arms and the fingers flare out. Babinski, the toes flare, and the stepping in place. So the complete physical assessment's done on the newborn within the first 24 hours of life. With general appearance, maturity level can be gauged by assessing this. You'll look at posture, the activity, anomalies that cause initial distress, any bruising, alertness, and resting position is inflection. You will be assessing temperature, heart rate, respiratory rate. That's always done. Blood pressure is not done unless there's cardiac problems or suspected. Temperature is done axillary, and you would take an apical heart rate and respiratory rate before doing the temperature so the baby is quiet. Normal axillary temperature is 37 degrees Celsius or 98.6. Respiratory rate depends on the activity level. Make sure you count for a full minute. Look for irregular, asymmetrical respirations or apneic episodes of greater than 20 seconds. Auscultate the heart rate for a full minute. The rate should be 120 to 170 after the baby's stabilized. And check pulses, brachial and femoral, for equality and strength. Place the neonate on a pad to protect against heat loss when weighing him, keeping a hand just above to prevent the infant from falling off the scale. Birth weight is typically from 2,500 to 4,000 grams, and that's 5.5 to 8.8 pounds. A tape measure is used around the widest part of the head to measure head circumference. That's the occipitofrontal diameter. This ranges from 32 to 36.8 centimeters, and that's 12.6 to 14.5 inches. The newborn is placed on a flat surface, and a tape measure is used from the top of the head to the heel to measure body length. The leg is extended as best as you can. Term babies range from 45 to 55 centimeters, and that's 17.7 to 21.6 inches. Caput succedaneum versus cephalohematoma. On the left, you'll see caput succedaneum. This is an edematous swelling that extends across suture lines. If you remember cap, like if it's a cap, it goes around your head. It can extend across suture lines. This disappears in 3 to 4 days, and it's due to pressure on the head during labor or even a vacuum extraction. A cephalohematoma, on the other hand, is on the right side of the slide. This is a blood accumulation between the skull and the periosteum. It does not cross the cranial suture line, and it can occur simultaneously with the caput succedaneum. It can occur because of forceps delivery or spontaneously from pressure against the bony pelvis, and this can resolve usually in 3 to 6 weeks. So we're assessing the skin color. Average findings are usually pink or acrocyanosis, which is common after birth. you'll see some normal variations such as skin modeling or Harlequin sign. Harlequin sign is characterized by an asymmetrical sweating and flushing of the face and neck. You could see plethora, and that's a beefy red coloration of the newborn. They look like they have a bad sunburn. Or telangiectasia, I can't say it, the telangiectasia, okay. And that's widely open blood vessels in the outer layer of the skin. And these are usually called spider veins. I like to call them spider veins, it's easier to say. Or deviations from normal, you can see pallor, grayness, dark red spots, or petechiae. Remember, petechiae are the pinpoint round spots that appear on the skin as a result of bleeding under the skin, or ecchymosis, you can see. Assess for jaundice. Average findings, you will see none at birth, but physiological jaundice happens in the majority of newborn infants. 60% of term infant babies can have that. And normal deviations are jaundice within 24 hours. So jaundice within 24 hours is fast, so that's a little worse. Yeah, you want to keep an eye on that. Hemangiomas, you'll find under birthmarks and bruises. These are non-cancerous growth that form due to an increased, an abnormal collection of blood vessels. They are congenitals, and most disappear by age 10. You can see port wine stains, strawberry marks, or cavernous hemangiomas. Port wine stains ordinarily persist throughout life, and the area of skin affected grows in proportion to general growth. Port wine stains occur most often on the face, but can appear anywhere on the body, particularly on the neck and the upper trunk. Early stains are usually flat and pink in color, and as the child matures, the color may deepen to a dark red or even purpley color. Strawberry marks are hemangiomas that grow during the first year of life, and then they recede over time. A child who had a hemangioma during infancy usually has little visible trace of growth by age 10. So on the left you'll see a child with plethora that looks like a severe sunburn. In the top middle there's a port wine stain, and that's called that way because it looks like port wine if you were to spill some on your tablecloth. Followed by a cavernous hemangioma and a strawberry hemangioma. Couple of pictures so you can tell what they look like. And here on the left you'll see meconium staining on the cord. So it has that greenish color, so this baby had some meconium stained fluid while in utero. On the right hand side you'll see Mongolian spot on the buttocks of this baby and a little bit on the back. These are commonly found on the buttocks, but they can be found elsewhere, usually as multiple spots or as one large patch, and it covers one or more of the lumbosacral areas, the buttocks, sides, and shoulders. It results from entrapment of melanocytes in the lower half or 2/3 of the dermis during their migration from the neural crest to the epidermis during embryonic development. And you'll see that a lot in dark-skinned babies. Black babies have that. All right. So with the skin assessment, you are going to inspect and palpate it, noting the intactness, smoothness, texture, any edema or pressure points. Average findings, you'll see a little edema around the eyelids. Due to the prophylaxis, that'll make the eyes puffy. And the skin, you'll see some opacity, some large blood vessels, particularly over the abdomen. Some variations, you'll see some superficial cracking, peeling of the hands and the feet, and a few large vessels visible on the abdomen, and babies usually scratch their faces with their fingernails, so observe for any scratching, and then the hands need to be covered if that is the case. Deviations from normal include edema in the hands, feet, periorbital hydrops, overhydration, pre- or post-term infants, then smooth or rash or superficial peeling. For preterm infants, numerous vessels are seen on the abdomen, and post-term, you'll see thick parchment cracking and peeling. You can see skin tags, webbing, papules, pustules, vesicles, ulcers, maceration, and milia. Now, milia are the little tiny, they look like little whiteheads. Do not pinch them and try to squeeze them. They go away by themselves. Okay, so again, we're talking about the skin. You're going to routinely weigh these children and check the skin turgor. Notice for presence of fat. Dehydration in infants is assessed by weighing them. You can do a skin pinch test in the children who you can also put little bags over them to collect urine and measure the urine. Normal variations are weight loss of 10% of their birth weight. That occurs in the first few days. Typically, babies lose a little weight after they're born, and then they gain it right back. You will see some puffiness or some subcutaneous fat variations. So some deviations from normal, you'll see loose, wrinkled skin, tense, tight, shiny skin, and lack of subcutaneous fat. Vernix caseosa could be present, or you might not have any on the skin. Note the color and the odor. Normally it's white, and they call it cheesy. It's odorless, and it's found in creases and folds. It may look to see if there's any odor to it or green coloring from meconium. Also assess the skin for lanugo hair. You'll find that normally over the shoulders, the pinnas of the ears, and the forehead. Amounts vary, but in post-term babies you'll see that usually it's absent, and in preemies you have a lot of lanugo hair. Here is a photograph of Vernix caseosa, also known just as Vernix. It's the waxy cheese-like substance found coating the skin of newborn human babies. Vernix starts developing in the baby in the womb around 18 weeks in pregnancy. It has a highly variable makeup, but is primarily composed of sebum, which is oil, and cells that have sloughed off the fetus's skin and shed lanugo hair. Vernix is theorized to serve several purposes, including moisturizing the infant's skin and facilitating passage through the birth canal. It serves to conserve heat and protect the delicate newborn skin from environmental stress. Vernix is also thought to have an antibacterial effect, though there's little evidence to support a chemical role of Vernix in protecting the infant from infection. It may form a physical barrier to passage of bacteria. During fetal human development, the lanugo grows on fetuses as a normal part of gestation, but it's usually shed and replaced by vellus hair at about 33 to 36 weeks of gestational age. As the lanugo is shed from the skin, it's normal for the developing fetus to consume the hair with a fluid, since it drinks from the amniotic fluid and urinates back into its environment. Subsequently, the lanugo contributes to the newborn's meconium. The presence of lanugo in a newborn is the sign of a premature birth. Here you'll see molding of the head. We like to call this cone heads. We call these little cone head babies. Make sure that you teach your patient and the family that this is normal deviation, and it will go away in a few days. This is just normal. Our skull is not fused when we're neonates, and that is so that we can make it through that birth canal. The skull of the normal skull of a newborn, we have two major fontanelles, and they are the anterior and the posterior. These are also called soft spots on your baby's head, which during birth enable the bony plates of the skin to flex, allowing the child's head to pass through the birth canal. The ossification of the bones of the skull causes the anterior fontanelle to closes about 9 to 18 months. and the posterior fontanelle close during the first few months. So the posterior closes first. Excuse me. The closure eventually forms the sutures of the neurocranium. Assess the fontanelles daily. You're going to look for sunken fontanelles, which means that that baby is dehydrated, and if the fontanelles are sunken and that baby's dehydrated, we need immediate medical intervention. It is also a sign of malnutrition. Bulging fontanelles are also an emergency. This is a very tense or bulging anterior fontanelle indicates excuse me, raised intracranial pressure. Excuse me. Sorry. It can occur due to encephalitis, which is a swelling and inflammation of the brain due to infections, hydrocephalus, and that's a buildup of fluid inside the skull, or meningitis, an infection of the membranes covering the brain. Ears and eyes. Observe the ears and check them for open auditory canals. Check the placement line drawn through the inner and outer canthi of eyes, reaching to the top notch of ears and cartilage, and make sure it's well formed, the cartilage. Lack of cartilage is seen in preterm babies. Low placement of ears is indicative of chromosomal disorders, mental retardation, or kidney disorders. Tags or sinuses can be seen in the periauricular area. Check that the eyes are evenly spaced. Each eye and the space between occupy 1/3 of the total space. Epicanthial folds are characteristic in some ethnicities, but can be present with chromosomal disorders such as Down syndrome or Cry-du-Chat syndrome. Corneal light reflexes should be symmetrical. Sorry, I have a frog in my throat. So the blink reflex should happen when a light is shined into the eyes and then the infant blinks. Movement of eyes should be symmetrical, and check for a red reflex, and that's the red color seen when a light is shined into the eyes. Lack of this may indicate cataracts. Conjunctiva is inspected for redness, and this can indicate infection from STIs such as gonorrhea or chlamydia. The nose should be midline of the face. Some deformities are normal deviations from the birth process. Observe to see that there are patent nares. Neonates are obligate nose breathers, meaning they breathe through their nose. They don't know how to breathe through their mouth. So observe for nasal breathing. This is a sign of respiratory distress. It's because they're obligate nose breathers, make sure that you suction those little noses out when you, if you see any flaring or if you hear any excess mucus or see any. For the mouth, you're going to observe for symmetry of the lip movements, for cyanosis or gross anomalies such as cleft lip or palate. Check for any erupted teeth. That happens sometimes. Look at the color of the tongue and check for protrusion and free movement. Gums should be pink. You can see Epstein pearls and bone nodules sometimes. These are white, hard nodules on the gums or the roof of the mouth, and they're normal variations that eventually disappear. A normal chin is distinct, and some syndromes can result in a recessed chin. Here are some pictures. Bones nodules are the smooth whitish bumps or cysts that are sometimes found in the mouths of newborns. They are found at the junction of the hard and soft palate and along lingual and buccal parts of the dental ridges away from the midline. They are benign and usually disappear within the first 3 months of life. Epstein's pearls are whitish yellow nodes that appear on the gums or the roofs of the mouth, and sometimes they look like emerging teeth. Epstein's pearls usually disappear in a month or 2 after birth. Malformations of the chest include pectus exhibitum, which that's like a sunken chest. You're going to be checking for the shape and symmetry. Look for any retractions or unequal movement, or check for fractures of the clavicle or crepitus, which is the noise that you make when you move, cracking, crunching noises. The nipples should be well formed and symmetrical, and look for any accessory nipples. Preterm infants will typically have less breast tissue. And of course, you'll be auscultating the heart and the breath sounds. Inspect the umbilical cord for 2 arteries and 1 vein. There should be no odor, and the clamp should be left in place for at least 24 hours. Look for hernias or distension, and check for bowel sounds in the chest with severe respiratory distress. This can indicate a congenital diaphragmatic hernia. Look for decreased or absent abdominal movement when breathing. With the genitalia, for the female, you would inspect the clitoris and labia. Usually in the females, the genitalia is edematous. And check for ambiguous genitalia. Sometimes you'll see blood-tinged discharge in females, and this is called pseudomenstruation. It's caused by hormones. It's perfectly normal, and teach your moms that not to worry about it. It happens because of changes in hormones. Check that the infant has urinated for within 24 hours. On males, you would inspect the appearance of the urinary meatus, and that make sure that it's at the tip of the penis. The scrotum is usually covered in rugae, or it is always covered in rugae, I should say. Check for undescended testicles. The cremastic reflex is present, and that's when the testicles retract when it's cold. The extremities, arms and hands, always check for flexion and range of motion, symmetry of motion, and muscle tone. Look at color, malformations. Look at the palm creases, simian lines, and webbing, syndactyly, the absence or excess of fingers and toes, or for tremors. Look at palmar and plantar reflexes. For the legs and hips, you'll inspect the gluteal folds for hip dysplasia. Look for lines on the soles of the feet. The Ortolani maneuver and Barlow's tests are techniques in which the hips and knees are flexed 90 degrees and the thigh is gently abducted. If there's a palpable and audible clunk as the hip reduces, it's a positive finding. That would be for like a hip dysplasia. Observe for extra folds in the thighs. The Galeazzi sign is when the feet are placed firmly on the table and the knees are not symmetrical. This is caused by a dislocated femoral head. On the back, inspect for straightness and ease of flexion. Is the infant able to raise and support its head momentarily when prone? Are the shoulders, scapula, and iliac crests lining up in the same plane? Look for pigmented nevus with a tuft of hair located anywhere along the spine. This is often associated with spina bifida. Look for any sinuses or a meningeal seal. The magnet reflex occurs with lower limbs extended as pressure is applied to feet with the legs in a semi-flexed position. Here is a meningeal seal and a pilonidal dimple. Okay. Meningeal seal obviously is much worse. A lot of people have the pilonide dimples. So you're going to inspect the anus and look at the stools. Passage of meconium normally happens within 24 hours of birth. However, it can take up to 48 hours, and that's normal. The sphincter response is tested by stroking the skin close to the anus and observing the muscles of the anus retract, and they call that an anal wink. Fecal material can drain through fistulas and pass into the vagina or urinary tract. So the stool appearance begins with meconium, which is a black, tarry, sticky goo, and it transitions to a softer consistency and can change in color depending on whether the infant is breast or bottle fed. No stool indicates obstruction or a non-patent anus. Checking sensory behavior, vision, there's lack of accommodation for the first 3 months. So with a newborn, they can see up to 2.5 feet away. The best visual distance in a newborn is from 8 to 12 inches away. This promotes eye-to-eye contact with parents and promotes bonding with mom during breastfeeding. Normal vision is as acute as an adult's by age 6 months. But newborns already hear mom's voice for all those years in utero, and they know mom's voice and respond to it. Hearing loss, however, is a common major abnormality at birth, and all infants are screened for hearing loss before discharge. Newborns can differentiate between the smell of their mom's breast milk and that of another mom. Newborns are responsive to all touch, but especially on the face, hands, and soles of the feet. So now we're going to talk a little bit about newborns at risk. Who are newborns at risk? The preterm infant, and that is defined as the infant less than 37 weeks of gestation. Preterm babies have immature organ systems and lack adequate physiologic reserves to function in extrauterine environment. The lower the weight and gestational age, the lower the chances for survival. The incidence of preterm births is higher in lower socioeconomic groups, which is likely because of lack of prenatal health care. Other factors associated with preterm birth are gestational hypertension, maternal infection, multifetal pregnancy, premature dilatation of cervix, and placental or umbilical cord conditions that affect the fetus's nutrition. Late preterm infant is defined as born between 34 to 37 weeks. These are at risk for problems with thermoregulation, hypoglycemia, hyperbilirubinemia, and respiratory infection. So with thermal regulation, you would monitor the axillary temperature every 30 minutes until stable and take steps to minimize chilling. Keep that baby warm and cover the head. Excuse me. Hypoglycemia, you would monitor for signs of this, and that includes jitteriness, cyanosis, apnea, hypothermia, poor body tone, poor feeding, lethargy, or seizures. Hyperbilirubinemia, observe for jaundice from the first 24 hours and monitor bilirubin levels. With bilirubin therapy, we're going to cover their eyes and put them under the lights. Make sure you offer additional fluids. These babies need to be assessed for hydration status on a continuing basis. And we do that by measuring the volume of the urine and by baby weight. Physiological jaundice happens in most babies, as I said before. And this is due to the amount of unconjugated bilirubin during the first week of life. But pathological jaundice appears in 24 hours or in greater than 14 days of life. You'll see pathological jaundice happen within the 24 hours, and you'll see rapid increases in the blood bilirubin. Observe for feeding problems, assess the suck, swallow, and breathing, check for respiratory distress, hypoglycemia, thermal instability, feeding methods, or weight loss of no more than 10% of the body weight, and initiate early feedings. Respiratory function in these babies. Look for nasal flaring, grunting, tachypnea, central cyanosis, retractions, and monitor O2 levels with pulse ox and provide oxygen. These are the babies that they're going to run under the radar sometimes because they're a late preterm, they're kind of term but not really, so keep an eye out on them. Others at risk situations, Birth trauma, such as cephalohematoma, caput succedaemia, occurs because of the vacuum or forceps abstraction or the fetal skull against the maternal pelvis. Perinatal asphyxia, facial nerve paralysis, clavicle fracture or humerus, brachial plexus paralysis, or phrenic nerve paralysis are all birth traumas. Some congenital anomalies include GI malformation, neural tube defects, abdominal wall defects, cardiac defects, and hydrocephalus. The most significant cause of neonatal morbidity and mortality is sepsis. The most common infecting organism in sepsis is E. coli in early onset sepsis. Late onset occurs from 1 to 4 weeks, and that's usually staph or Klebsiella, Enterococci, Pseudomonas candida. Viral infections acquired perinatally can cause congenital malformations, neonatal disease, and even stillbirth and miscarriage. Maternal substance abuse includes all recreational drug abuse, tobacco smoking, and alcohol. Cocaine and marijuana are the most commonly used substances by pregnant women. Opioid-addicted moms result in low birth weight infants in 50% of the babies born to these moms. Fetal alcohol syndrome produces CNS effects, and some are not detected until the child is older. Infants exposed to chemical substances in utero exhibit sets of behaviors labeled neonatal abstinence syndrome. These babies will be poor feeders, they'll vomit a lot, they'll have diarrhea and suck extensively. They're irritable, they have tremors, and a shrill cry that's incessant. They're hyperactive and they can have convulsions. You'll see tachypnea, sweating, frequent yawning, increased respiratory rate, nasal congestion, and even fever. You must allow extra time for these babies. They need extra time for feedings. Okay, torch infections. What are torch infections? If we take the first letter for all the yellow boxes, T-O-R-C-H, toxoplasmosis, other rubella and cytomegalovirus, and herpes. So toxoplasmosis is found in the feces of cats and in raw meat. Greater than 70% of infants affected have no symptoms. But complications include preterm birth, intrauterine growth retardation, microcephaly, hydrocephaly, thrombocytopenia, jaundice, fever, petechiae. 10 to 15% of these babies die, and 85% have severe psychomotor problems or mental retardation, and 50% have visual problems if they have toxoplasmosis. So these are infections, by the way, that mom has that affect babies. Gonorrhea is acquired in the vaginal canal during the birth process, but we give eye prophylaxis of the erythromycin at birth to prevent the ophthalmos neonatorum. Complications from gonorrhea include conjunctivitis, gonococcal arthritis, septicemia, meningitis, and an infant can die from an overwhelming infection. Syphilis. Infants are given penicillin or E-mycin if sensitive to penicillin. Syphilis can cause complications such as preterm labor, neurosyphilis, deafness, notched incisors, joint involvement, saddle nose, tumor to the skin, corneal lesions, anemia, maculopapular dermal rashes on the palms, soles, diarrhea, mouth, and anus. Varicella is chickenpox. Babies born to moms who have developed chickenpox between 5 days before birth and 48 hours after birth are given varicella zoster immune globulin. Acyclovir for those who with generalized involvement, and pneumonia. If mom was infected in the first half of her pregnancy, there is risk of limb atrophy, neurologic and eye abnormalities, intrauterine growth retardation. And if it was in the last few days of pregnancy, there's a 30% of neonatal mortality rate. With hepatitis B, Infants born to moms with Hep B are given the immunoglobulin. Okay. So let's go on. Rubella and is another torch infection. Cytomegalovirus and herpes simplex are more, I don't think they're going to go too much into them. Let's go on. Hemolytic disease. Let's talk about this. You have two kinds of hemolytic diseases. There's Rh incompatibility and ABO incompatibility. So Rh is when an Rh negative mom has an Rh positive baby. The mother forms antibodies against the fetal blood cells. Women will become sensitized in their first pregnancy, and antibodies will cross the placenta, resulting in fetal anemia, neonatal jaundice, and hyperbilirubinemia because of lysis of the fetal red blood cells. Blood droplets from the fetus mixing with mom's blood sparks the formation of antibodies. This can happen with abruptio placenta or placenta previa, or manual removal of the placenta, C-section births, and if there is an increased risk in multiple gestations. IgM antibodies are formed first and then IgG. But in subsequent pregnancies, antibodies form in response to repeated contact with the antigen from fetal blood, and lysis results. Rh immune globulin is given to women who have identified Rh incompatibility at week 28 of pregnancy, and then again within 72 hours of birth, if the baby is indeed Rh positive. This ensures that subsequent pregnancies will be safe. With ABO incompatibility, this is more common and less severe. It occurs if the fetal blood type is A, B, or AB, and mom is O. These babies are at risk for hyperbilirubinemia, and this is treated with phototherapy. The American Academy of Pediatrics recommends that moms breastfeed exclusively for the first 6 months of life and to continue as the only source of milk for the first year. Colostrum is the first milk produced in the breast, and it's very high in antibodies and immunoglobulins. It's high-octane milk. It has a laxative effect that helps with the passage of meconium. The breasts start making this at about 3 to 4 months of pregnancy. Babies who are breastfed have lower rates of diabetes, infections, obesity, and allergies. Breast milk is also easier to digest, so these babies will eat more often. Babies who breastfeed have less offensive odor to their poop, and it tends to be yellow and seedy looking. Breastfeeding is also beneficial to mom. It promotes rapid uterine involution and less bleeding, a reduced risk of breast, uterine, and ovarian cancer, earlier return to pre-pregnancy weight, and decreased risk of postmenopausal osteoporosis, and it also promotes bonding. Contraindications are for infants with galactosemia. Mothers with active tuberculosis or HIV were positive for human T-cell lymphotrophic virus type 1 or 2 should not breastfeed. Also, moms receiving chemo or radioactive isotopes, and for those who use street drugs, should not breastfeed. Inexperienced moms and dads who decide to formula feed need support and teaching. Bottle feeding is a time of close contact, bonding, and socializing with the infant. Teach the parents the importance of washing their hands, thorough washing of bottles and nipples. Always check expiration dates, use tap water to reconstitute powdered or concentrated formulas, and do not heat the bottle in the microwave. Do not ever, ever, they tell you. Test the formula on the wrist and discard any opened formula after 24 hours. Bottle babies eat normally every 3 to 4 hours, not going more than 4 hours between meals. Newborns will consume 15 to 30 milliliters per feeding, and this increases during the first week of life, and they'll be eating up to 150 milliliters by the end of the second week. If the infant is gaining weight, then you can let them sleep past the 4 hours until they wake up for a feeding. Otherwise, wake them every 4 hours. So for techniques, you want to hold the infant for all feedings. Never prop the bottle. That's more patient teaching also. Hold the infant in a semi-upright position with good head support, and hold the bottle so there's no air in the nipple. When the infant ceases to suck, or he falls asleep, or turns his head away, that means they're done eating. Make sure that you burp the baby several times during feedings, and teach different burping positions, such as sitting position or on the shoulder or across the lap. With elimination, it's not unusual for bottle babies to have one stool every other day. Formula is not as readily digestible as breast milk. So now we're preparing for discharge, and you want to teach patients how to care for the cord and the circumcision. Tell them to always check for bleeding and to apply pressure if there is any. Check for urination, apply petroleum jelly, and clean with water and not wipes. Baby wipes sometimes have alcohol in them that would really hurt to a circumcision. Diapers should be changed every 4 hours to prevent sticking to that circumcision. Be gentle and provide extra holding and feedings, and give them their binky for a few days. Sucking really comforts babies. They need their binky. Assess knowledge deficits in mom and dad. So if there's the first baby, you may want to have to do more teaching and talk about safety issues, such as not placing the infant on his tummy to sleep. Teach them how to use the bulb syringe, not to leave the infant in the car, never to leave the baby alone on a bed or a couch or a water bed. Teach them how to take an axillary temperature, to watch for irritability, lethargy, poor eating, subnormal temperature, how to take the temperatures, fussiness, crying. So if you have an irritable baby who is pale, not eating, and has a subnormal temperature, that is a sign of a bacterial infection. Babies don't function like adults, so they won't typically have the high temperature with a bacterial infection. With respiratory respirations, always protect babies from secondhand smoke. Teach parents that there will be normal variations in rate and rhythm of respirations. Teach them about sleep positioning, never to place them on their belly. And if they're going to use cornstarch, to apply it on their hand first and then to the baby to prevent inhalation. Teach them about cold symptoms and raise the mattress 30 degrees to promote breathing if the baby has a little cold. And to use saline drops in a bulb syringe to help clear the mucus from the nose. Teach them that when they do use the bulb syringe, to press down on it to empty it of air, and to also suction the mouth along the sides of the mouth first and then the nose. And teach them breast or bottle feeding facts, elimination patterns and colors, and to look at the urine color and to make sure that the baby has 2 to 6 voids a day at least. Diapers should also be changed as soon as possible after urination or stools, and the perineal area should be cleaned with a mild soap and water. Avoid baby wipes with alcohol and scents. The skin should be dried before re-diapering. Infants are given hepatitis B immunization before going home or before 1 month of age, and get 2 more at 1 and 2 months of age. And with follow-up care, parents need to plan for follow-up care after going home. The infant should be seen in 3 days to assess for jaundice if breastfeeding or discharge is early. And also with the car seat, babies do not go home from the hospital unless the car seat is positioned correctly in the car and facing backwards. If they don't know how to do that, they can go to any fire department, I believe, and they will assist the parents with correct installation of the car seat. And that is my presentation today.